Hello, I'm Dr. Corinne Lefkowitz, a senior military behavioral health psychologist with the Center for Deployment Psychology. One of my areas of expertise is the behavioral treatment of insomnia disorder, and so I'm aware of the challenges that can arise around sleep logs. We know that sleep logs are critical to behavioral treatments like BBTI, but we also know that patients don't always follow through with completing them as accurately as we would like. I'm here today with my colleagues, Doctors Diana Dolan and Tim Rogers, both of whom are psychologists and assistant directors at CDP. We're going to discuss a few different strategies that providers may use if a patient doesn't bring a sleep log into their session or brings an incomplete log to session. As we're going to discuss, there's no single right way to handle this common situation, and a lot of our decision making may depend on the clinics that we're working with and the patients who are sitting in front of us. So with that said, I'd like to welcome Doctors Dolan and Rogers to chat today with me about sleep logs. I'd love to hear your thoughts about and your experience of how you handle the issue of incomplete sleep logs within BBTI. And perhaps I'll start with you, Dr. Dolan. How do you typically handle this?
Well, hello, I'm glad to be here today. I think if a patient doesn't bring in the sleep log, the first option that you have is pretty straightforward. It's simply to just not continue with the appointment and to reassign the sleep log and tell them that when they bring it back in completed, then you can proceed with appointment 2 of the protocol. If you do decide to have a policy like that across the board, I recommend you let patients know in that first appointment that when they come back in for appointment 2, in order to proceed with treatment, you will need a completed sleep log or you'll have to reschedule. Having that policy across the board sets really clear expectations for engagement that you expect your patients to follow up on recommendations. It lets them know that you, as the BHC, value their log, that you need their log. It underscores that the sleep log is really a key ingredient for treatment. You might use the example if you want to use an analogy of a patient who hurt their knee. If you hurt your knee, you would want your physician to take an x-ray before telling you you need a cast. So you need that data, that information before you can tell them what they need for their sleep. So use that time in appointment 2 instead to focus on adherence. You can strengthen the patient's commitment to treatment, reinforce completing it daily, and again, really set that expectation up front of what you need. If you are deciding, if a patient comes in and you are deciding, do I want them to reattempt this sleep log, or do I want to just proceed with a guesstimate? So maybe you're not telling every patient that they have to reattempt the sleep log. You're deciding in that moment. There's a couple things you can use to gauge that. If it seems like the patient is not really fully engaged when they come back in without a completed sleep log, I do recommend reassigning the log because how likely is it that the patients are going to do the 4 rules or a new sleep schedule anyway if they're not really that motivated to do their log? So that's one sign to me that the patient may not be ready. And then if they do reattempt and complete the sleep log, then I'll know, okay, they're a little more invested at this time. You can also evaluate whether or not you think the patient is an accurate historian, looking at the answers they gave in appointment 1, whether they were broad or specific. Do their responses when you ask questions seem exaggerated or straightforward? What is the patient's level of self-awareness or conscientiousness? And if the patient doesn't seem like they would be able to make a good guesstimate based on those factors, you can just reassign the log at that point. Remember when we were in training and we asked you to remember the last few nights of your sleep log, how difficult it is to be accurate the further back we go. So starting with last night might be difficult, but then the night before, and so on. We go backwards. It's harder to remember that data. So we know that regardless of what got in the way of the patient completing their baseline sleep log, the data is not going to be as helpful. The likelihood of not getting the best sleep schedule to start with is higher. And if you don't get the best sleep schedule to start, you have to reset later down the road. This can be demoralizing for patients and it can actually undermine treatment, even if it's carefully done.
Well, thank you, Dr. Dolan. You brought up a number of good points. And rather than repeat everything you said, I just want to highlight a few of the takeaways that I got from that. One, I very much appreciate as a provider, as a BHC, being really straightforward and upfront about what you need in order to deliver good treatment, and making that analogy of how the data that we collect from that really directs treatment, really directs our recommendations, and why that's important. And really being clear about that, and not having a lot of surprises about what might happen if a patient comes back without a sleep log. I also, though, appreciate that you have some thoughts about how you might be more flexible with that, and some of the things that you might consider, which include things like how much of a good reporter the patient in front of you is, and how invested they are. Because what's the point of kind of giving a pass on not having the sleep log initially if they're not going to be invested with the rest of treatment anyhow? I really appreciate those points. Before I go any further, I want to check in with Dr. Rogers and get his ideas. Do you agree with those points, or would you handle this a bit differently?
Well, thanks, Dr. Lefkowitz. I appreciate the opportunity to speak with everyone. One of the things that I really noticed is that for a lot of providers, if you're not able to get a sleep log or it's partially completed, that a lot of people have questions about how to proceed. And for some, feeling like, okay, does this mean I can't do any of session two with a particular patient, right? And so I do think that there's some flexibility that can be utilized in session two. My first point is we have to keep in mind that really the most important data that we're going to get from session two is really, what is their average total sleep time and what is a good wake time? And we're going to use these two data points to help set their new sleep schedule. Okay. So there's kind of two scenarios that I'll talk about. First, if a patient comes into your session and doesn't bring any data, no sleep log completed. In terms of my own training, being very CBT oriented, my training kicks in about making sure that we reinforce that school in that tool that we're trying to get the patients to practice, right? So they can't avoid. So even if for whatever reason they weren't able to do it, then I'm still going to take that time to practice them using the skill in session, right? And so most likely what that would look like if my patient came in and they didn't have anything would be at least starting with the last nights of sleep, as Dr. Dolan mentioned. That's usually what they're going to have the best sense of. And then what I'm going to probably ask them is how normal, how typical was that of how their week went? So I know as the further they go out, they might not necessarily have the best sense, but I still want to get some sense of, whatever data they get, how typical was that for the cross of the week? Could they give me some sense of it, right? The other scenario is going to be, maybe they had a couple days worth of sleep data that they bring in. So they didn't do all 7 days. They only did it a couple days. So the same thing here. I really want to get some sense of how normative was that data. Were those like the best days out of the week? Were those the worst days out of the week? And I want to get some sense of that, because even though when you're doing a guesstimate, it's not maybe as accurate as if they were filling out every day, right? I still want to get some sense of how normative this was for them, because regardless, even though I might still be able to try to give them a new sleep time based on this guesstimate, right? Based on my sense of what was typical, best to their recall, I want to let them know that, we're adding some guesswork into this. And the more accurate they can, the more that we can address and remove these barriers so they can fill this out better, the better able I am to give clinical recommendations for them. My goal ultimately here as a therapist is that I not only want to help them in the most effective way, but the most efficient way. And to help them in the most efficient way, we really need to make sure that we're getting accurate data. So even though I might be a little bit flexible and try to work with them, because most providers have this concern of how frequently am I able to see this patient? How often are they going to be able to come in? When am I going to be able to see them next, right? So there can be a strong pull for us as therapists to still kind of push forward in a treatment protocol. But everything that we're mentioning here, I think, are really good points for us to think about and being intentional as therapists about why am I moving forward, or how am I moving forward with the patient, and why would that make the best sense? And how can I do that in the most reasonable manner?
Thank you, Dr. Rogers. That was a really thoughtful take on how to be more flexible. And I appreciate that you articulate really clearly that if you are being flexible, that you're talking with the patient directly about what some of the limitations are with that when you're using guesstimates, that also may influence how good, what quality of intervention you're delivering, and that there's a little bit of a cost to doing that. Not that you can't do it, but there is a cost associated with it. As I'm hearing you both talk, obviously it's clear to me that there are several ways to approach this problem. And as we started out by saying, no one right answer. The commonality that I hear from both of you is that you're really keeping with the spirit of BBTI, that is the behavioral components, needing the data from the sleep log and wanting to reinforce the completion of the sleep log. But beyond that, it seems like how you intervene will base partly on the patient who's sitting in front of you, the patient population as a whole that you're working with, and even the parameters of the clinic that you work with, and for example, how frequently you can see patients. So again, it's clear to me that there's no one right or wrong answer. It's going to be based largely on circumstances and clinical judgment. So my recommendation is that I now turn this back over to our BBTI trainer and lead the group in a discussion about what would work best for the clinics that BHCs are working on.